Welcome everyone to this side event on drug consumption rooms. I'm happy to see so many people. There has been some miscommunication because in the previous program there was another room. This was the speakers were disappeared for a while. So I'm happy to have everyone here. My name is Catherine Schiffer. I'm the head of Correlation European Harm Reduction Network, the global network based in Amsterdam. And we are also chairing the European Network of Drug Consumption Rooms, which is an informal network of around 30 drug consumption rooms in 23 cities across Europe. I'm very happy to chair this side event together with Hugo Faria next to me. He will introduce him in a second. And shortly about this side event. So, drug consumption rooms, or DCRs, are supervised facilities where people can come, they can use their drugs which they bring with them in a safe and hygienic environment. And this is under the supervision or with support of the staff working there. We know that these services help to prevent overdoses, they reduce transmission of infectious diseases, and they also connect people with essential health and social services, and very often these people are very much excluded from other services. And evidence also shows that drug consumption rooms benefit the wider community. They help to reduce public drug use, decrease discarded syringes, for example, in public spaces, and contribute to safer neighborhoods. And also, we all know that many countries still remain very hesitant when it comes to the development and the implementation of drug consumption rooms. Very often this is linked because there are some legal questions or political sensitivities, misconceptions about how these services operate. And at the same time, happily, we also see that more and more countries are interested in drug consumption rooms because they work. And this is not only in Europe, but also in Asia and South America. So this is why we organized this side event, and we deliberately chose not to have all kinds of presentations. We only have one wonderful presentation from Jim Mountain from the EUDA. And after that, we will engage in a kind of round table discussion, which is not a round table discussion, there's no round table, but the idea is that people contribute from their very specific background. So we have policymakers from different countries, from 3 countries, I don't know, Google will introduce them, and we also have practitioners from 4 countries, and we have also Marie Chauffret, who is with a research perspective. So a great panel and a great group of speakers. Idea is, if we are all having time at the end, we can probably also have some questions. I hope so. So I'm looking forward to the discussion. I give the word to Hugo, who will present himself.
Thank you. I'm Hugo Faria. I work for an NGO named Miao for a long time, and we work from prevention to treatment, so we have also harm reduction projects. But for me, it's very grateful to be here because it's again bringing the subject of drug consumption rooms to the CMD in Vienna. I will just say some words. So it's a pleasure to be participate in this event organization, and also to be with so many people, some colleagues, some friends, some partners. So the topic of consumption room is also very close to my heart on a personal level, because I had the opportunity to participate in the entire process of creating and opening the first fixed room in Portugal, and have remained connected to the project ever since. So it's very clear that these kinds of facilities serve the populations for which they are intended and have, among other things, a very simple purpose: to care. And caring for individual and public health, and playing an important role in connecting and referring people to health and social services, particularly among the populations most excluded from these systems. This happens even when in their creation and or operation, DCRs face some resistance or a more skeptical view. So a consumption room is undeniably a facility with unique conditions to reach people with drugs, welcome them, and guarantee something that should be basic for everyone, so access to care, health protection, and dignity. Regardless of the model, more clinical or more community-based, drug consumption rooms do not exist solely to allow drug use, but they are also structures that promote health and well-being, not only for the people who use the service, but also for their families and the communities in which they live. So the event, even if in the current context of uncertainty, DCRs continue to prove essential, not only because of their proven effectiveness, but also because of their cost effectiveness when compared to the social and health costs associated with the absence of this kind of responses, and even when it's compared to other interventions for people with drugs. So now?
I forgot actually to say that our event is being filmed.
Okay.
Yeah, so we hope that afterwards, it will take some time, that we will put it on our websites and you can access it.
Okay, so like Catherine was saying, so we will have some sections, different sections, policymakers, practitioners, researcher, and then ideally some comments in the end. So now we will move for the presentation of Dr. Jane Montley. So we will find out about how evidence could help our work. So Dr. Jane Montley is head of the Public Health Unit at the European Union Drugs Agency, the UDA, and has been at the center since 2010. She has been working in drug research, policy and practice since 1994, both at the national and the European level. So, please.
Thank you very much for the invitation. A pleasure to be here. I think the wonderful bit will come after, but this perhaps will give a little background to the discussions, which I think is the important part. But I think just to set the context, so drug consumption rooms are operating in a complex context, and the situation is relatively fast changing and it's diverse. New synthetic opioids, as we're hearing a lot about that, there's been a lot of side events. For some drug consumption rooms this really is an issue, for others maybe less so, but we are seeing some changes. Nitazines and orphins are around. Increasing cocaine on the European market, so again consumption rooms will be seeing people using crack, there'll be perhaps some changing patterns of use that they're having to deal with. Cathinones in some countries are gaining ground, and injections of cathinones. Polysubstance use, I think it's I don't know, the word gets thrown around a lot, but I think in terms of the implications for how we respond, they're massive, because we're not responding to single substance use, whether it's treatment, whether it's naloxone. There's some quite complex responses needed. You have to think about that. Also some of the semi-synthetic products that are on the market, and the new cannabinoids, which are highly potent. So there's lots of change and there's lots of different modes of administration. In terms of actually the high potency, because we're looking at trying to reduce harm, save lives. This is an old graphic with the test tubes, and this was just recognising that the new synthetic opioids, highly potent ones, are really easy to move around because you need such a little amount. And here it's 0.1 of a gram of carfentanil to create 10,000 doses. So on the left, what's a lethal dose, and you see here fentanyl on the tip of a lead of a pencil, or carfentanil. I mean, it's minute amounts that can be lethal. So we're talking, it's a different world, if you like, compared perhaps to when we're thinking back to heroin, etc. So just to bear that in mind. Okay. For me, this is a really interesting slide because it just shows how in Europe the preferred opioid is different from country to country, and actually even perhaps from city to city. This is drug-related deaths and the opioids that are mentioned. And what you see is, while heroin and actually methadone are found in autopsies still in a majority of countries, in some countries nitazine. So Estonia, Latvia, you see more nitazines than any other opioid. Bulgaria, fentanyl. Finland, buprenorphine. Sweden, oxycodone. So we're not talking about a unified situation, so drug consumption facilities, where they will be dealing with slightly different issues, even though the goals may be the same. And this may have different implications for for responses. I think always when thinking about responses and harm reduction responses, and here's a pyramid model we often use for responding to drug-related deaths, it's recognising that nobody's working in a vacuum. There are a range of responses, some of which we've got very good evidence for, some of which we've got less, but actually we need to do more evaluations because they may be really good, we just don't have much evidence. But you have got a level of reducing vulnerability, a level of preventing overdoses and a level where people have overdosed preventing death. And so you need kind of a range of responses if you're actually going to make an impact. In terms of the European picture, in terms of drug consumption rooms, as we know the first one was in Bern way back in '86 in Switzerland. Since then, we've got 12 member states in Norway who have drug consumption facilities, and maybe there's more opening. But last year, there were 3 new ones that we identified in Ireland, Czechia and Slovenia. What we see, and this visual shows the implementation across European countries of different harm reduction interventions. So you have OAT, the substitution medications are now kind of available in every member state. But you see interventions like take-home naloxone, drug consumption rooms have been slower and are kind of making some progress in terms of number of countries, but there's not full, by any means, availability across countries. I think Katrine gave a very good introduction to this, so I don't need to go into too much detail. But my understanding is drug consumption facilities, supervised consumption, they can be different, okay, but they often have similar aims, so reducing morbidity and mortality, the referral to other services, reducing public nuisance, and engaging people with high-risk patterns of drug use. But different services may also be provided. There's always the supervision of consumption, provision of needles, other injecting equipment, emergency interventions if overdoses occur. Primary medical care is very common and often referral to other services, advice and training, including on safer forms of drug use, overdose prevention, and very often linking to opioid agonist treatment. We know, and we will hear, I'm sure, in a minute, different program designs. So originally, facilities were focused on injection, and the other routes of administration, such as smoking, inhaling, we'll hear, I'm sure, are now used. Many are integrated as part of broader health services, but some still remain specialist, and that can include the outreach vehicles. We have quite a bit of evidence now. The quality is often not particularly high. We need more studies. It's something we've been working with Major Chauffeur on. But there's beneficial evidence for a number. I won't read out all the statements. I think Katrine mentioned some of them. But this is from our responses guide, so you can look this up online if you would like to dig in a little bit deeper into the evidence and what we know works. From our side in the pipeline, we've been working for some time now on a guide because we recognise that there's a lack of evaluations, lack of evidence. So we've been looking to develop a guide to help people evaluate their own services. This is both for the managers of consumption rooms and for local policymakers. We're also working with the network, European Network of Drug Consumption Rooms, on our own data collection, so we can actually identify some of the patterns of use that are going on, some of the harm, some of the substances. So this is something that we use the data that we get from the consumption rooms involved, triangulated with other sources. We have a number of publications, again, if you're interested, that you can access online. So go onto our website and you will find many of these publications. And just to finish, some of the things that we've flagged in terms of implications for policy and practice which may come up. As Katrine mentioned, the legal issues are quite key in some countries and they're really prohibitive and something that really needs working on. And also political consensus. The evidence base, which I mentioned, we need to improve it. Different models of delivery, I think, is something that's really interesting, and what the needs may be for consumption facilities for particular groups, and also integration of drug checking services, which I know is happening, and I think a really, really exciting development. we see that, as with other harm reduction facilities, consumption room are often the first to know what's going on. They you know, you're the front line, you get early insights into trends and patterns of use. So for us, it's really important to be in touch with you. Big role in terms of preparedness, particularly if there's also on-site testing. And it's also an opportunity for developing cutting-edge responses. So thank you.
So now we can move to the next section. So we will have the possibility to listen from 3 different countries. So we will listen to Czechia, Portugal, and Greece. At the national level, how it was to open a DCR and how it was the experience. I will start by presenting Victor Mrak. I was training hard, but yeah, Victor, yeah. So he's an epidemiologist focusing on substance use and addictions. He's the head of research and innovation in an NGO, Společnost Podany Rusi. Vice chairman of the board of the Society for Addictive Diseases of the Czech Medical Association and the scientific advisor to National Drug Coordinator. He's a member of the core team designing drug policy reforms, including decriminalization and legal regulation of so-called psychomodulatory substances or cannabis in Czechia. He's facilitated opening the first and only DCR in Czechia in the city of Brno. So please.
Yeah, thank you for a nice introduction. Yes, Czechia. In Czech Republic, it was the local initiative basically promoted by the NGO Společnost Podany Rusi, where I work as head of the research and innovations, with big support of the big city of Brno and municipality where the core of the drug phenomenon is located in Brno. So really local project, but also with support of the National Coordination Office for Policy in Addictions, including financial support. The drug consumption room was opened in September 2023, so it's been now 2.5 years basically of operation in a mobile form. It was a consensus of the local stakeholders to have it mobile, as you said, Jane, outreach vehicle. In a most vulnerable location of the city of Brno, with a lot of public injecting. And public injecting was basically the most important interest of the municipality and politicians from Brno city, of course, also public health imperatives like overdoses and infectious diseases, which of course was most important, or very important for us on the side of service providers. It should be mentioned here that it was open only in 2023. Okay, there were 2 years of preparation, involved the local stakeholders and other service providers, created a working group. We included also police and city police, discussed, and the consensus was to open it in a mobile form. It should be mentioned that it wasn't the first attempt, it was the first successful attempt. It wasn't the first attempt to open the drug consumption room in Czech Republic. Basically, the attempts to have drug consumption room, especially in Prague, was dated 30 years ago. So in the last 30 years, in different waves of urgency, I would say, it was discussed but never opened. The main reason why it was not opened that long, and at least so far in Prague, is restrictive legislation, and not only with regard to the drug possession, which concerns clients mainly, but also drug promotion, or drug use promotion, which concerns services. Yes, so there is at least theoretical risk of prosecution on both sides, client and services, and not only legislation as such, but also interpretation of the law and approaches, especially of the national police drug squad, which simply hampered those initiatives, at least in France. In Brno, we involved local police. What was important, maybe the most important element or the moment was we made an interpretation of the law, which allowed us to claim it's legal, to open it legally, and basically the interpretation says that the possession of the small amount of the drug means dose for use is equivalent to use as such, which is not criminalized in Czech Republic, and there were also the decisions of the courts in this regard, so we simply made it based on this evidence, and this interpretation at the end works well. There are now, I would say, initiatives at the national level to make the framework for functioning of drug consumption room more formal, and make some rules for the operation somehow set in the legislation. So we'll see how it goes. So, and I will finish. The last question was what I would advise to countries who are considering the opening drug consumption room. What should they take into account? Cooperation at the local level and with the national level, really to talk to stakeholders, to involve them to planning process. The project should reflect the local situation as much as possible. It should be informed process by the data. We made an estimate of the people injecting drugs in the center of city Brno, and so on and so on. Formal rules and procedures should be established, so the program has set certain rules which should be kept when using the service by the clients. And the main lesson learned I have written here is that drug consumption room, if designed carefully and reflecting local needs, is a standard service. After those 3 years or 2.5 years, it became a standard service embedded in the whole range of services in Brno City, operating within the outreach program. Nothing wrong happened, no incident, no extraordinary thing. Perfect functioning, helping people, saving lives. There were 2 cases of naloxone administration in the mobile outreach vehicle. Yeah. There is a cooperation with the emergency service, and it's also beneficial both for the clients and the local community. That's it. Thank you much.
Thank you so much. Okay, so now we can now move to the example of Portugal. So I would like to invite Joana Teixeira, which is the National Coordinator on Addictive Behaviors and Dependencies and the President of the Institute on Addictive Behaviors and Dependencies, which is a public body under the Ministry of Health, a position she has held since January 2026. Congratulations. She's a medical doctor specializing in psychiatry and holds a PhD in psychiatry and mental health.
Thank you for the invitation and allowed to share the Portuguese experience. I will address 4 main topics in my presentation. First of all, in which year was the first drug consumption room established in Portugal? Well, our drug consumption rooms were included in Portuguese law in 2001, alongside a broader harm reduction framework. However, their practical implementation came later. The first service was launched in Lisbon in 2019 as a mobile supervised consumption unit developed through a partnership between civil society organizations, the Municipality of Lisbon, and national authorities, specifically the Institute of Addictive Behaviors and Dependencies under the Ministry of Health. Since then, SURF is expanded and now have operating in Lisbon a mobile supervised consumption unit and 2 fixed drug consumption rooms, and in Oporto, the second biggest Portuguese city, 1 fixed drug consumption room and a mobile unit. These responses target highly vulnerable populations, including people experiencing homelessness and those using drugs in open urban scenes. Second topic is what were the main reasons and policy considerations that led to its implementation of drug consumption rooms in Portugal. 3 main factors supported the decision to move forward: evidence, territorial needs, and integrated responses. Briefly, international research shows that drug consumption rooms reduce overdose deaths, decrease HIV and hepatitis transmission, and improve access to healthcare and social services. Second, local assessments in Lisbon and Oporto identified open drug scenes, homelessness, high vulnerability, and public health risks. And third, drug consumption rooms were designed as part of a wider network, including street outreach teams, syringe exchange programs, opioid substitution treatment, health and social services, and housing and integration programs. Drug consumption rooms were therefore not standalone interventions, but integral components of a comprehensive care system. Third point in the presentation is, based in our experience in Portugal, what are the key benefits for drug consumption rooms? Well, drug consumption rooms are effective public health interventions that prevent avoidable deaths, reduce immediately health risks, and connect vulnerable populations with care and support. However, they are not a standalone solution. Their success depends on the integration with broader policies addressing addiction, housing, mental health, employment, and social inclusion. To illustrate their impact, allow me to share some figures from 2025. A total of 5,074 individuals used the fixed and mobile services, 1,500 of whom were referred to other healthcare providers. 19 overdoses were successfully reversed, and more than 61,000 sterile syringes were used within drug consumption rooms. Ultimately, the key question is not whether drug consumption rooms increase drug use, but how much harm would occur without them. They are essential risk reduction tools that protect both public health and human dignity. And to finish the first point, what would I say to countries that have reservations or concerns about establishing a drug consumption room? Countries that have reservations about drug consumption rooms often raise legitimate concerns, particularly regarding community safety, the potential normalization of drug use, or the fear of attracting drug activity. However, the experience of countries such as Portugal shows that when these services operate within a clear legal framework, integrated into health and social services, and supported by community engagement, they can reduce overdose deaths, improve access to treatment, and increase and save consumption in public spaces. Drug consumption rooms do not encourage drug use. They provide a targeted public health response for highly vulnerable people who are already using drugs in unsafe conditions. For countries considering this measure, the key is to approach it pragmatically. Based on scientific evidence, local needs a strong coordination between health authorities, municipalities, law enforcement, and civil society. Ultimately, the objective is simple: to save lives, reduce harm, and create opportunities for people to access care and support.
Thank you for bringing the example of Portugal. So now we can ask Anastasios to share a little bit about how it was in Greece. So Anastasios Trakakis serves as a consultant to the National Coordinator for Addictions of Greece, actively contributing to national and European drug policy. He played an active role throughout the entire process of establishing the first drug consumption room in Greece, and he is an associate professor specializing in indicators, tools, and data systems that support evidence-based policymaking.
Thank you, dear Katrine, dear Hugo, dear colleagues, dear friends. Well, first of all, it's an honor to be here and speaking about the DCRs on this side event. I'm going to share a little bit about our experience from Greece. Well, the first drug consumption room was established in 2022 in Greece, in Athens specifically, and it came to fill a gap in our harm reduction services. There was need at that time. The framework of opening the DCR was made by the Ministry of the Civil Protection at that time and not by the Ministry of Health. And that period was the period that we faced COVID-19. So that was important at that time. There is a need to mention that we had political support for that. The DCR was inaugurated by the Presidency of Democracy, and the first visit was paid by the Prime Minister himself at that time. And today we find ourselves having the stable DCR in Athens, a mobile DCR in Thessaloniki, and hopefully 3 more mobile DCRs to come in Athens in the next few months, hopefully. The need for creation of the DCR at that time was, of course, the high rates of drug use in specific urban areas, the prevalence of HIV/HCV, the overdose cases, the significant unmet health needs among people using drugs. So the decision to implement the DCR was based exactly on those things. First, to the urgent need to prevent overdose deaths, to the necessity to reduce public health risks, the commitment to a more human-centered and rights-based approach. And we also collected scientific evidence from European and international experience. Well, the main concerns and fears, I think it's something that we all have in common in some cases, like, for example, the stigma that exists, right? The political will, the funding, secure funding. The good thing for us was that we had political will, we had secured the funding, but there was the question of what will happen with the political cost that comes with the stigma at that time. So we had engaged ourselves in trying to convince people the importance of DCRs. Stigma was present, and we had resistance from the neighborhood, from the businesses operating nearby in the initial phase of that process, concerns from local residents, and we made it clear. We build services where the problem exists. We are not trying to we come and where the problem exists to reduce noise in the neighborhood, to support, to protect public health, okay, to manage responsibly and humanly the drug use so as to improve public health, generally speaking, in that neighborhood. Over time, with ongoing meetings and community engagement, perceptions changed. Residents began to observe improvements in the neighborhood environment and public health as well. We also invited them to come and visit the DCRs. We also paid visits to their businesses, and we showcased them evidence-based data from other countries, from other DCRs at that time. Data speak. Here in Athens and in Greece generally, we got more than 700 lives saved through the opening of the DCRs, and we have more than 8,000 individuals registered. So, key recommendations for cities planning to open a DCR. You may use data from other DCRs. This is the reason that we have created the ENDCR to support, to exchange knowledge, best practices, to monitor data, and give that knowledge to us, other countries to follow. transparent communication, community participation, continuous evaluation, strong political will, but above all, honest. Okay, so be honest. Advocate for political commitment, engage the local community, listen to concerns, invest in staff training and education, integrate civil society, and be patient and persistent. That's the point here. When we choose evidence over fear, dialogue over stigma, and humanity over hesitations, we save lives. Thank you.
So,
Thank you very much. Yes, sir.
thank you, all three, for this valuable contributions. I think it's, especially coming from a more practitioner background, it's extremely good to hear also the perspective of policymakers, not only go to policymakers and ask for things, but also hear their concerns. We know that it is not easy to sometimes make a change, and unfortunately we also know that only evidence unfortunately does not work. It's not convincing enough. So very often we see that the final thing which makes the opening of a drug consumption rooms is very often not predictable. It can be a person, or it can be that someone visits drug consumption rooms and thinks suddenly, hey, this is really a good initiative. So I think this is what we always need to keep in mind. From the policy perspective, we now go to the practical experience. So we have a great group of practical people from, we have someone from Paris, we have someone from Ireland, we have someone from Portugal, and we have Portugal, no, and someone from Barcelona. So I start with Aura. Barcelona has an experience of 20 years with drug consumption rooms, and looking back on these 2 decades of drug consumption rooms implementation, what has changed? Is it better? Is it getting better? Is it getting worse? Where are we?
Right now, we are in a dangerous position because we don't know what's going to happen with the harm reduction services and everything. But of course, to have DCRs, and it's not one, are like, I think that we are around 13 in Catalonia, minimize criminalization. I don't want to repeat the results because we can see that. But what we saw also is that people is alive, but they are not living, they are surviving. Because we have been chronifying the situation of exclusion. The DCRs are designed for drug use, but what we are finding in the DCRs is homeless people struggling with mental health, needing protection from violence against women, and we are not ready for that because we were designed for drugs. Also, now we have a lot of professionals working on the DCR that they don't have harm reduction perspective. And they think that harm reduction is just an adding of strategies, providing needles, or just providing methadone. But at the same time, they think that harm reduction is just the minimization of harm until you get better. But no, harm reduction is something that we implement every day. And if we can do it at home, safe, with our friends, is different than you are in the streets, etc., etc. What we saw is that we need to develop other kinds of services. That includes safer spaces to use inside, but not designed as a DCRs, because we are not talking about drugs. We are talking about homelessness, violence, etc., etc. What we found after 20 years is that of the total population that goes to the DCRs, right now 15% just, or between 10 and 15, are women. They have not safe spaces for them, and especially when we are talking about gender-expansive people. Also what we found is that less people who use drugs are included in the design, the implementation, the monitoring and evaluation when they are experts, and we know that this means that the arguments that we are using each time more is more about social control, it's about disease, and it's not about well-being and safety and protection, as they saw. Then we suggest also that we should put people in the center, include the people inside the design, implementation, the monitoring and evaluation that we need, and also go from a community model. We are part of the neighborhood that we are serving. We need to open the doors, not to close them. And our experience is that when we work from this perspective, and we work with this feeling of belonging, of being part of the neighborhood, of being cachet, is how we break a stigma. And in our case, for example, we have the acceptance of the neighborhood. We have the support of the small business around us. Then, and we do, of course, handle action. We do the safer spaces inside, but we do a lot of activities outside. We do theater, we do radio, we do, because what happens is that we are not attending people who use drugs. We are attending the people who use drugs that has been rejected from the rest of the networks of support. Then now we need to open our minds, and I'm going to say that, please, open safer spaces for people who use drugs. Try to not open a lot of DCRs.
Thanks, Aura. Very nice. I go to Elisabeth Avril from Gaia. She's from Paris. She's the director of Gaia. And I think your story is very different because you are currently operating a drug consumption room with an evaluation framework. And I think already for the third or the fourth time it's linked as to an evaluation or a kind of pilot project. Can you elaborate a bit on this model, why this is still such an evaluation? And
Well, thank you for the invitation. In France, we have 2 DCR, one in Paris, one in Strasbourg. And I think the experimental framework was necessary to prove the benefits to public opinion, but also to politics. That's what the politics said when we opened in 2016. And the positive aspect of 5 studies, reports, and 1 study is going on, and I think we are going to have another one, is that it provides scientific evidence regarding the effect on DCR on user health, public health, economic aspect, public safety. I'm not going in the detail because I think Marie is going to talk about that. But for us, the negative aspect was following the first evaluation of the first 6 years of experimentation, the DCR should have been permanent, but for political reason only, the government decided to extend the trial period for further 3 years. So in June, last year in June 2025, the government was due to decide on the future of the DCR in accordance with the law, based on the various studies and reports. But the government, French government, preferred to wait until the last moment, that was end of December 2025, to authorize 2 more years of trial, so until 2027. So this situation is really stressful for staff and for users, and it's about, excuse me, a fool's game, because always asking for new evaluation with new criteria, and now the new criteria are based on detoxification, rehabilitation, abstinence. We are a drug consumption room in Paris with 350 injections every day. So what can we do about abstinence? Okay, we can do things, but it's a bit of nonsense. And these evaluations, they are not using them to make the DCR legally sustainable. So for us, it's a flagrant lack of political will that endanger users, goes against science, against human rights, and costs money, because every evaluation costs money. And yet our work, everyday work, saves life. Every day we are doing, intervention, overdose, reporting to hospital, visiting people to hospital, social work, but everything we do and more. And this work is recognized by the community and by science. So this situation and this political reluctance has impact because it leads to a delay in implementing new action needed by the community as opening new DCR. In Paris region, it's 12 million inhabitants. We have one DCR, and people are complaining that people are coming to us. So, you know, it's like a full game all the time. So it's a bit difficult to support because we are well accepted and stable in the network and neighborhood. And we know now how to do the job because we didn't know 10 years ago. So now we know how to do the job. But we are a bit tired of this endless evaluation and non-decision, political non-decision. That's what I can say. Thank you.
Thanks. I think it clearly shows that it really requires political will and courage to go on, and that one drug consumption room per city is definitely not enough. So let's go to the next practical example from Ireland.
Thank you.
Eddie.
Thank you. So I'm really struck by the similarities of the contributions. We've all experienced the same challenges and the same resistance. Ireland opened its first. We're a supervised injection facility, so we're not a full DCR yet. We only allow people to inject drugs in our facility. We opened in 2024. December 2024, and like Paris, we're a pilot. We're an 18-month pilot, but I'm really worried now that we'll be 10-year pilot, having listened to your experience there. We're an 18-month pilot due to expire on the 24th of June this year, and we eagerly await decisions from government. I suppose what I wanted to maybe explain was the experience we had in getting to December 2024 when we opened. So the idea of a DCO was first mooted in 2015 in Ireland, and it took 9 years from the day a very brave minister came to Cabinet and said, I think we need one of these facilities in Dublin. It took 9 years to get to opening our facility in December. And last week at our National Parliament, a member of the Department of Health was presenting on a number of, actually on the new National Drug Strategy, and there was a conversation or a question in relation to the medically supervised injection facility, and he had statistics that we obviously had provided because we're independently evaluated, and there's a lot of data which is gathered and collated and shared. So we have had 15,500 visits, 1,500 people visit the facility, 280 non-fatal overdoses. And what struck me was the department, for the first time ever, actually put a number on the number of lives saved. And they on the record in the National Parliament, they said that 16 people were still with us today because the facility had opened. Now, given that we've had 270 plus non-fatal overdoses, I don't know how they got the figure of 16. But one person saving one life is what it's about. So we were very happy to have that figure put on the national record. But it wasn't plain sailing. When this brave minister brought this to Cabinet, we had to go through a series of processes. We had to amend our legislation that went through the National Parliament. We also, as the operator of the facility in our building, which is in the centre of Dublin, in the tourist area of Dublin, so a very sensitive area. When we went for planning permission, we had 99 objectors, from local schools to our court services directly opposite us, right across the gamut of society. We had 99 objections. Actually, Dublin City Council, which would be the new municipality, they objected, and they were the planning authority, so they refused planning. So we had to then go to an appeals process. And the appeals process, we were successful, subject to several conditions, and that was appealed, and then went back to our court service, and then eventually back to our planning appeals board, and the decision was taken to grant the opening of the facility. And because it's a pilot facility, we are now back in that process. So we had to reapply for planning permission to continue to operate the service. And we had one objection this time. So from 99 to one objection. And listening to the other contributors today, what was so important was over the last 12, 14 months was that engagement with local communities, engagement with the school, and we have a community outreach team who are out there talking to people, both people who use our service and people who live in the community, and had a lot of concerns about the development of this site. And I think it's so important for events like this to demonstrate that the sky doesn't fall in when you open a drug consumption room, and that it is a facility that is designed to support some of the most marginalised people, and we know that. And I was interested, Victor, in your comment about rules, because the one thing we've learned is we have to have minimal rules, because we're dealing with people who, have been ostracised and I suppose refused access to so many services. To put rules in would just be another reason why they wouldn't access our service, and that brings challenges. So we have a big problem retaining staff. We have a high turnover staff. It's a very challenging environment to work in. If you're on a shift for 9 hours and you're working with people who are, I suppose agitated, sick, unwell, angry for many, many reasons, it can be very difficult for our staff. And that's the one area at the moment that we're looking at to see what we can do to maybe make it a little bit more, a little easier for people to work. And finish on that. Thank you.
Thanks. Very interesting to listen. I'm really sorry for cutting off, but we are in time. So, from there, let's go to Hugo from Portugal.
Again. So I will briefly explain how it was, because many things were said about how Portugal opened first DCRs, but the fact is that it takes almost 20 years between the law, the 2001 law, and the first DCR opening, which is, you can say it's too much time, but in fact I was thinking that there was some attempts to open DCRs, but I think that this time that we could open, all the partners involved, when we pushed, we had the possibility to open. So I mean that when the problem was hard, was very serious, so many people were, again, since the 90s, so it was some fears from the 90s again, people sharing needles and using drugs everywhere again in Lisbon. So when this picture came again, starting in 2016, all the partners stayed together, and we had a great support from the municipalities, for example. So many people were talking about this. So it takes so many times because we really need unique conditions to open a DCR. I don't agree with that, but it's a fact, and that's why it takes so many time. It also takes so many time in Portugal because since 2000, it's always the same, 2000, 2001, but in fact the Portuguese government invested a lot in distributing all kind of resources when it comes to addictions services. So it takes a long time to build like a network, so it wasn't assessed like a necessity to open a drug consumption room during a long time. Only when, and also I have to say also that there was a disinvestment, which is also a problem. But when the problem came, the fact is that we could open probably later than it should be. But and I would just highlight that we could open because of the reality, because the drug consumption rooms in the streets was again a problem very visible, but also for this unique situation. And unfortunately, the City Council of Lisbon, there was a unique consensus of political and partners, and also from the National Institute of Drug and Drug Addiction, all together make it possible. Otherwise, I'm not here talking about DCRs in Portugal. Thank you.
Thank you. So, from the practice, we go to the research. I would like to introduce Marie Chauffet-Rousty. She is the research director of INSERM Paris and has extensive experience in research around drug consumption rooms and evaluation.
So thanks, Catherine, and thanks to Correlation for inviting me, and thanks to ESSDP for welcoming me in their delegation. So to conclude somewhat, I will try to be short. So we are now at a turning point in harm reduction policy, which particularly affects drug consumption rooms dissemination all over the world. The populist movements that dominate some parts of the world are also emerging and disseminating in Europe. They constitute a threat to progressive drug policies, to the human rights of people who use drugs, and to freedom and trust in science. This populist shift tends to underestimate the advances in public health, public safety, and human rights made possible by drug consumption rooms. We have now strong evidence-based research on the effectiveness of drug consumption rooms, including cohort studies with control groups that are the gold standard for policy evaluations that have been published in high-ranked journals. Literature has shown that drug consumption rooms have an impact in decreasing infectious disease and overdoses, as well as a positive impact to help to reach very vulnerable people to have access to health services and to decrease the number of discarded syringes in public areas. Despite these large benefits, drug consumption rooms still face difficulties to be disseminated in some countries. We now need to change our narrative to help drug consumption rooms to be strengthened and disseminated. To do so, it's very important to counter some false discourses and controversies about drug consumption rooms by highlighting evidence-based data produced by research as well as informed-based data produced by harm reduction workers and people who use drugs who attend these services. The first controversy we need to deconstruct now is a discourse that tries to oppose harm reduction and recovery. In practice, drug consumption rooms save lives and are a real path to recovery. If we want people to recover, people need to have the opportunity to be cared, and drug consumption rooms help vulnerable people to be alive, because drug consumption rooms welcome people as they are, without moral judgment or stigmatized attitudes. The second controversy we need to deconstruct tends to oppose public health and public safety. Research has shown that drug consumption rooms improve public health by allowing people to inject in safer spaces. This opportunity has also an impact on public safety by limiting the number of injections in public, and this limitation also constitutes a benefit for public safety. To overcome controversies associated to drug consumption rooms, there is also an urgent need to have an open dialogue with police officers, politicians, and residents. Opposition to drug consumption rooms is very often linked to a lack of information and to misunderstandings on how drug consumption rooms work in practice, which impact they have on people's lives, and what research has highlighted regarding the effectiveness in public health, human rights, and public safety areas. That's why we need to create meeting spaces for having a shared dialogues on fears that opponents can have, to listen to the voice of people who use drugs, who have their lives improved by drug consumption rooms, to listen to the experience of harm reduction workers who have informed evidence to share about the impact of their works on public health, human rights, and public safety, and to take seriously into account what research have produced regarding evidence. To conclude, I'm also convinced that local and international successes are key to convince the national politicians to take evidence-based and informed decisions. We need to open the dialogue, but to do so, we also need to convince politicians to be open-minded, to have this dialogue with us. That means finding politicians willing to be committed in harm reduction, which is a real challenge during these troubled times.
Thank you. So we just thought, so we are actually over time, but I think we are not directly being kicked out. So if there are burning questions, I think we should allow. Burning. So I think I saw first yours, then behind you. I saw 4 questions. Ooh, 1 corner. So first, you will be there too. Yeah.
Hi, my name is Yuralix. I worked at the Safe Consumption site in New York City, and one of the big problems that I saw there was the balance between including people with lived experience or people who actively use drugs and like workers' rights or workers' well-being inside of the safe consumption site. So I was wondering if any of you can speak on that, like how, because like obviously the policy is really important to making it happen, but if it's not sustainable because the workers are being treated really badly or they're really burnt out or there's not other mechanisms for care while also including people with lived experience in the safe consumption site, then it's another really big piece that I'm curious if anyone has any responses to.
Is there anyone who could think of what? Yeah. In Paris, we used to, we had some user asking to be volunteer, and step by step we included them as normal employees, like they are paid like as the other with their. So we try to make the equivalence with people with diploma, and some people without, and we have a few of them, and trying always to recruit, to have quite a mixed staff. But it's not so easy because we have a very good, strong support from our regional health agency. But in other parts of France, for example, they could ask for the diploma and say, no, these people must not be there because he's not a real social worker and he has no diploma. But in Paris, they just let us, and in the DCR, first they said that they shouldn't go inside where the people were injecting. They were not supposed to come. But we are not presenting them as, we are presenting them as normal employees. So nobody's going to check if they were or are or review them. So it's a bit of a trick like that.
I'm not giving the opportunity to all panel members, but so can you do it? And then.
Okay.
Not me. Oh, go
Immediately behind you.
Okay, so
there is a whole group.
Yeah, this is a question.
My name's Mary, and I'm working on the safer drug consumption facility in Cali, Colombia, which is a very different context. But we've seen a tension between kind of trying to offer a safer, kind of like what Aldo is describing, right? A safer space that's really community oriented and is able to reduce the kind of wider social harms that people are experiencing, with being able to integrate the public health services. And I just wondered if you have thoughts on kind of navigating those tensions.
I couldn't understand the question. What is the question?
Just around like the challenge and the tension between balancing the kind of more community focused, kind of broader harm reduction work with integrating these public health services that have different methodologies and indicators and objectives.
For us, it was crucial to put the women in this, where they were defining what was more important, and for them was in the same level to be able to take a shower, to belong to a group, or to use drugs inside. Who are putting the drugs in the front is us. But for them, all of them are in the middle. Then when you are working and you set the person in the center and they are defining what is more important, these tensions become less important. And also because they can change all the time. We don't have rules. Because if we have rules like then, and they are part of all the directions, or like people who use drugs, part of all the different decision-making process. Then you can adapt to these tensions that are always going to appear, but you need to adapt and answer to them together.
Okay. We just got a kind of that we have to get out. So make your questions very short, and then both of you start. And
Okay, so my name is Jakub Nowak, and I'm from Polish outreach organization Social Initiative for Narcopolitics. And I'm thinking about, do you have any experiences with, because you told about the drug consumption rooms focused on this most vulnerable group of injection users, mostly of opioids or injection stimulants. But thinking about the group of recreational users in outreach spaces, for example, summer festivals, they don't have any place to use drugs. Do you have any experiences with mobile drug consumption rooms in outreach perspective?
as far as I know,
In a recreational setting, I mean,
Yes.
in the nightlife setting, for example.
Yes.
as far as I know, because we talked about it in the corporate of the European Network of Consumer, there is not really, this is not happening. I think there would not be, at least I don't know of any of those. I wouldn't know an example, but I can check. And what I would suggest that if you come later, I give you my card, send me an email, and I can
Okay.
forward your question to the
Okay, I
broader.
will be.
And this applies to everyone else.
Thank you very much.
Just to say, in Ireland, the Department of Health, they attend music festivals, they test drugs on site, and they talk about how they, I suppose, educate people on harm reduction. They don't provide a facility for people to take drugs, but they're there to support people who take drugs if they run into difficulties, if the issues haven't taken drugs, and they test drugs on site. So, and they go around the various music festivals in Ireland providing this service. So it's a halfway house between what you're saying and supporting people.
Yes, we make this kind of service.
My question.
The last question.
Yeah, so this is on the evidence base. Jane, sort of a question for you, because you did this slide with the evidence base saying that the evidence base was quite low and poor on all of these various indicators. Now there's several hundred. Oh shit! You're right. Yeah. Sorry. Sorry. There's almost 200 now. They've been around for several decades. These are some of the most scrutinised public health interventions in the world. I've read, there's been hundreds of very detailed studies on with a whole range of indicators. I don't understand how that can qualify as a poor evidence base. It strikes me that the evidence base is actually extremely strong. And it's kind of problematic because we hear from government, well, the evidence base is very poor, very poor. So I would question that as an assessment, and both politically, and it speaks to what Marie was saying as well, that it's problematic in terms of advocacy to say there's a poor evidence base when the evidence base is actually amazingly good, I would say. Is that a sort of conceptual thing that we can't do RCTs with these, or we can't do controlled studies? And given that we can't do controlled studies, do we not have to get beyond that and say, look, there's a really good evidence base here, but it's not...
Yeah, and that's exactly what it is. And
We need to get
it's
past
low.
that,
It's not
though.
poor, but it's low, and the direction's positive, and it's improving, actually. So it's, you see, new things have come in that have added to that table that weren't there before. So it's a moving target, but yes, it's not that it's the quality compared with RCTs. So, and that's true for all harm reduction, unfortunately. I mean, it's almost not needle and syringes, but you can't do really RCTs.
I think this is a great topic for a follow-up site
In the
event
bar.
next year.
Supervised drug
So thank you all for being here. I would like to thank Alex Ruki for doing the recording.